Good evening. Um, my name is John Elfar. I'm this guy over here. I'm part of a team of people, and we're all excited to talk to you tonight about uh, hand infections. I wanted to title this something other than hand infections, but we titled it hand infections. This is our disclosure information. We have no financial relationships. I wanted to call this Everybody Loves Hand Infections. I think I like dealing with hand infections because they're some of the cases that we know we can make better. Our objectives today are here. We want to identify the major types of hand infections. That's important. We want to describe some principles of management, recognize some controversies, few of them exist, and appreciate that infection management and some prevention is part of hand surgery and all surgery practice. So there's some Zoom recommendations from AO. Try to have your microphones muted, and then you use the Q&A for questions related to the discussion topic, not chat box. So I'm going to begin. These are two pictures. This is Hippocrates and this is Knavel. And Hippocrates' principles of the treatment of hand infections, which are thousands of years old, are still valid today. Wounds were in his time kept clean with wine-soaked dressings. We don't use those anymore, but dressings were kept loose so that pus could escape and flow away freely. Knavel was a surgeon. He was a general surgeon in Chicago, and he demonstrated the potential spaces of the hand. He did very elegant experiments to do this, and he also demonstrated the pathogenesis of infection, and we still use a lot of his surgical principles today. What's important about hand infections is when you look at a hand, immediately you'll start to get a feel for what's going on, the etiology, the likely organisms, the involved structures, and the necessary workup. Not all of these are infections, but it's important for you to keep in mind a wide differential because a lot of things can look like an infection and not be an infection. And we're going to get into that right now. First, let's talk about the patient evaluation. Most of the diagnosis and infection management comes from a history, and that's true for a lot of things in surgery. When there's an inciting injury, or was there a progression of symptoms? Is there erythema, pain, swelling? How long has that been there? We want to know about other things like immunizations and allergies, and when the patient's most recent meal is, especially because surgery is considered for a lot of these infections. Malnutrition, alcoholism, autoimmune diseases, steroid use, hepatitis, and HIV status. These are critical things to know. But if you have to pick one comorbidity to know about, you want to know about diabetes, and that affects 11% of the population, and it complicates the management of these patients. On to physical exam. Once you know your history, you want to get some objective data and look for some signs of infection on your physical exam. And you also want to decide whether or not ancillary studies are necessary. And the clinical examination remains the hallmark of the diagnosis of infections. Latin words like dolor, which means pain, or calor, which means increased temperature or heat, and erythema, which is rubor. These are sort of classic parts of the picture for infections, and these are important. Temperature elevation isn't consistent in hand infections, and so I don't think that we should use that as a chief way to know whether or not an infection is there. When doing your physical exam, you always want to look at the surrounding unaffected skin. You want to mark things, and we're going to get into that in a second. But you also want to look at the contralateral limb. Clinical evaluation also includes examination for things like fluctuance, warmth, and edema, and lymphadenopathy proximal to the infection site. Next, general treatment principles. Often the initial decision for formulating a treatment plan is to decide if the patient requires a procedure or if it can be managed with antibiotics. And this is something that takes some clinical judgment. Early infections or cellulitis are often treated with inpatient admission and IV antibiotics, as well as serial exams. But if you have a collection of pus, that's really not appropriate to manage without surgery. Surgery, when it's done, has to be done through an incision that's large enough to allow pus to drain. And those incisions are often packed with packing or Penrose drains to prevent them from closing early. Because a key principle of management, this is important, a key principle of management is allowing the pus to drain and allowing it to be exposed to the outside. So these wounds are not often closed. Other principles that are important are early initial splinting, but early motion. All right, we're going to get now into some common infections. And I think that everybody knows these or needs to know them. This is a paronychia. This is an example of a paronychia. Paronychia are soft tissues infections of the lateral nail fold. These are really common in children and are more common in women than in men. It's the most common infection in the hand, and it involves soft tissue folds around the soft tissue fold around the nail. If it's untreated, it can extend below the nail plate and into the entire eponychium. I want to call your attention to these pictures. These are pictures of management. We don't routinely get X-rays of these patients unless you're looking for a foreign body, and you want to see here's the pus beneath the eponychial fold. You want to sort of see that, and this is what this looks like when you look. This is a pretty routine paronychia. Sometimes these require more debridement or less, depending on how involved they are and how long they've been there. The general principle is drainage, antibiotics, and warm soaks, and you need to evaluate that nail bed. All right, there is a chronic paronychia. This isn't always a neglected acute paronychia. A lot of times treated acute paronychia present as chronic paronychia. And it's important for you to know that these have to be treated in a different way, because a lot of times they've been drained and they just keep coming back. One of the elements of treating these is called marsupialization. And this is what that is. It's actually removing the skin over the nail fold, not removing the nail matrix. That's what this picture is supposed to depict, and here as well. And just doing this actually prevents these infections from continuing. They call this eponychial marsupialization. Next, we're going to talk about a very common infection. This is called a FELON. 15% of all hand infections are FELONs. These are subcutaneous abscesses in the distal pulp of the digit. The swelling does not usually extend proximal to this distal interphalangeal joint flexion crease. Swelling causes decreased venous return, and these are often tight and indurated, and abscesses form. This is a slide depicting, on the right side, is depicting a classic way to drain these laterally. These are very common, and when you drain these, you're supposed to use longitudinal incisions. This is not the incision I use, but it is the incision that many people use. Some people just go straight up the middle of the tip of the finger. It's important to not get into the flexor tendon sheath proximal to the distal interphalangeal joint. So it's important to stay distal to the distal interphalangeal joint so that the flexor tendon sheath isn't seated. These are treated with antibiotics, maybe packing. Sometimes you can't fit packing in these, but definitely soaks. And they usually heal pretty well. If gone untreated, they can be a problem. And I was once called to the emergency room with a finger compartment syndrome. This was the actual diagnosis. Untreated FELONs can go on to chronic problems. I personally haven't seen this, but these are present in textbooks. Skin necrosis, and they can result in osteomyelitis and amputation. Pyogenic flexor tenosynovitis is the next infection we're going to talk about. And you should look. The thing to see in this picture is this reddened digit. We use Knavel signs as markers or signs of a closed space infection in the flexor tendon sheath. These infections destroy the gliding mechanism and they lead to loss of functions. Tendons themselves gain their nourishment through synovium and a direct blood supply, and the bacteria live there and they live off the synovium. So they actually enjoy the nutrients within the synovium. And this area has a poor blood supply, and so it can lead to expansion of these infections pretty quickly. It's important to know that the history of an actual injury is often not there. I wouldn't look for it. These are common organisms that cause flexor tenosynovitis. Management has classically been some IV antibiotics and surgical treatment. I think a lot of us are moving towards a not immediate surgical treatment in some of these patients, but in the most severely affected patients, surgical treatment as an emergency is the standard. And we can talk about that later as well. Pyogenic flexor tenosynovitis is drained any number of ways, and it's irrigated any number of ways. This is one way that I don't typically use, but through a proximal and distal incision with irrigation flowing through the finger, either retrograde or antegrade or retrograde. These are classical approaches, midlateral or midaxial approaches to the digit that allow you to drain these. It's important to do this in these patients. You want to consider splinting after the surgery initially, but these fingers are classically moved while the patient is in the hospital with therapy. It's really important, or else the finger can be permanently stiff. When left untreated, I personally haven't had any of these left untreated, but when left untreated, it's important to know that very bad things can happen. The worst thing that can happen is spread to another part of the body, but necrosis of the finger is a pretty close second. They often result untreated in amputation, and untreated, they lead to a digital ischemia that's pretty reliable. And these infections can turn into polymicrobial infections, even when they don't start out as polymicrobial infections. We're going to talk briefly about deep space infections, and it's important to know what we're talking about. There are septated spaces in the hand, and these septated spaces lie between fascial planes. There's a thenar and mid-palmar space that can get infected. Here's an example of a thenar space that's full of pus and a mid-palmar space that's full of pus. The tight fascia on the volar aspect of the hand limits the spread of these infections to different muscular compartments. And these can be very painful. Mid-palmar and thenar space infections in the hand are located dorsal to the flexor tendons. These are the flexor tendons, and look at these spaces that are dorsal to them. It's important to know these relationships. The mid-palmar space infection can often result from a penetrating injury to the tendon sheath, and the hallmark is the loss of this palmar concavity. If you're looking at the top of the hand, the top of a normal hand is supposed to have this, the volar aspect of the normal hand, the palmar anterior aspect of the normal hand is supposed to have a concavity. And these mid-palmar spaces, one of their classic signs is that they have a convexity to the hand. I don't have a picture of that. I only have it in this diagram. There's a fourth space, and it's not hand space. It's called peroneal space, and it's in the distal forearm, and it's between the peroneal quadratus and the FTP tendons. And it can get involved by spread of a hand infection. I'm going to show you that in another slide. Deep space infections in the hand often. Uh-oh, hello? Okay. Deep space infections in the hand often come from penetrating injuries, like foreign bodies on the x-ray that you can see on the x-ray. The organism is almost always Staph aureus, and you'll see a lot of redness, a lot of swelling, no convexity to this hand, but still pus leaking out of a penetrating wound that was probably a few days before. The treatment is incision and drainage. The treatment of many of these infections is an automatic surgical procedure. IV antibiotics, elevation, packing, and Penrose, and these patients are admitted to the hospital for monitoring. There are incisions that are classically used for some deep space infections. I wanted to show you this generally pretty safe thenar incision, or this dorsal first web space incision. Here's another variant of that incision. These are pictures that once you see them, you know what to do when you have pus in these hands in these places. Out of all these incisions, I think I've used them all. I have never used and probably will never use this. I think it's oriented in the wrong direction for me. But what's important is that These infections, when drained, they can be combined with other procedures that relieve a patient's symptoms. Keep in mind that the carpal tunnel is not immune to infection. And so you can make these incisions in extensile fashion to allow you to do what needs to be done to preserve critical structures in the hand. We're going to talk now about the collar button abscess. These happen because patients have little cracks in their skin that can sometimes split open and get infected. I've never seen this from a paper cut, but I have seen this in patients who have very rough skin with psoriasis. And you can see the abscesses right here, and they are drained through any number of these incisions. In general, we don't carry this incision from this side onto the volar side in the exact same orientation. It can create a scar contracture that's somewhat difficult to deal with later. Look at the abducted position of this finger relative to this finger. It indicates the presence of this abscess, even though you can only see that on the volar side. Okay, collar button abscesses, I told you about the fissures in the skin, red swelling, firm, and pain in the abducted fingers. And again, the treatment is not, there's no rocket science here. It's drainage and packing and soaks and IV antibiotics. I want to show you the BURSAE because this is what we were talking about. There's a peroneal space up here in the forearm, and infection of the BURSAE, here's a radial bursa, and here's an ulnar bursa. These infections can spread through the palm and infect juxtaposed bursae. These are different and distinct from the tendon sheets we were talking about before. And that's that when they communicate like this, it's shaped like a horseshoe. They call it a horseshoe abscess. Now we're going to talk about bites. This is the best picture I could find when you expand it. It's pretty blurry. This is a fight bite, a bite suffered in an altercation. Here are the holes directly over the metacarpal phalangeal joint. The mechanisms, I have never seen it inadvertent. I've always seen it through bites with a patient with a clenched fist. Here's a picture, a radiograph with a tooth in the patient's hand. These are pretty rare. So when you find one of these, you keep a picture. The organisms are organisms that are common in the in the human mouth: Eikenella coronans, Strep viridans, Staph aureus, and Bacteroides. The treatment is surgical exploration, and you have to be aware that sometimes when the hand is flexed like this and the fight bite is suffered like this, the tendon injury ends up proximal to the metacarpal phalangeal joint. Just opening up over the tendon injury doesn't expose you to that punctured capsule and that infected joint. It's something to be aware of. Complications from this, most commonly from neglect. Human bites can turn into human bite nightmares, like this picture on the right. Look here, an extensive debridement for an underdebrided fight bite infection. And this is what I was telling you about, the line of injury, but when the finger is extended, the extensor tendon rupture is proximal to where the joint is. Let's talk about animal bites. These are really common, 1 million dog bites a year, most commonly affecting very little kids. Cats are 5% of animal bites, but they're 76% of infected bites. The dog lovers on the faculty here probably enjoy this fact. Organisms are Pastorella multicoda. This is a cat, a very classic cat question. The other versions of bacteria that come up in these questions are much less common. I still answer staph after Pastorella when I'm asked a question about this on a test. The treatment is antibiotics and surgery, but don't forget that tetanus, don't forget that tetanus update or the animal rabies status. You got to ask about that because those are bigger problems than simple infections. I wanted to talk to you about the difference between a cat bite and a dog bite. Look at these teeth on this dog. This dog has broad, blunt teeth. There is structural damage to nerve tendons and joints, but these are not severing. These are not severing teeth. Look at this cat with its sharper teeth, narrow. These wounds tend to seal when the tooth leaves, and they can penetrate deep structures. Maybe this is a reason why cat bites are much more commonly associated with bad infection. Maybe they're just cats. There are things that are not infections, and we have to know about these things because if you treat these like infections, you actually harm the patient. This is a classic example, herpetic whitlow. These, if debrided, get worse. And it's important to sort of know, if you have a wrestler or you have a dental worker and you see vesicles, these probably ought not be unroofed. It will make things worse. It's caused by HSV1 or HSV2. They're two different sort of herpes viruses. It has this prodromal burning. Before the vesicles show up, the patients have pain. Then they have swelling, erythema, and then the vesicles. You can do this zonk smear on the test, but I've never done it personally, and I haven't had any of my residents do it all throughout my career. But viral cultures are done. Treatment is non-surgical. That's the important point. Antivirals are used nowadays. It used to be that only immunocompromised patients got it, but antivirals are actually used in non-immunocompromised patients. The natural history is self-limited, but they recur very often. All right, septic arthritis. We're getting towards the end here. Septic arthritis. The etiology is usually a penetrating injury, but you can get hematogenous spread, like all septic arthritis in the body. Adults can have a tendency towards gonococcal involvement. In my experience, staph is still more common than that in adults. It's just that gonococcus is common enough to get its distinction here. Presentation is erythema, edema, and pain with axial loading. That's a classic example. You're looking for swelling confined to around a joint. You're looking for lab values like CRP and ESR. Aspirates of joints should have greater than 50,000 white cells and glucose more than 40 below serum levels. The theory here is that the bacteria use up the glucose in their surroundings. Radiographs show a foreign body often. Osteomyelitis, you can sometimes get the idea that there's air in the soft tissues. Septic arthritis, the goal is to drain near the joint. In the hand, you want these lateral approaches. These aren't done through Bruners and little zigzags on the volar aspect of the hand because you're looking for a big flap of tissue to cover over. You are looking for something that you can open up 2 days later if it's not getting better. And through the distal interphalangeal joint, a lot of people use this. Why? I use these H-shaped incisions for that, going on either side of the tendon, trying to preserve the tendon. Complications are cartilage destruction, something that we do not have a cure for in 2020. Osteomyelitis because of spread, and these can result in amputation. Necrotizing soft tissue infections, these are things to mention. These are life-threatening, limb-threatening infections, and they can be some of the worst things that happen in your practice over your career. They're rapidly progressive. The mortality is anywhere between 10 and 75%, and in my personal experience, it's greater than 50 for sure, percent. They can occur from minor or major trauma, and they can occur spontaneously. These infections are a forest fire of the fascia. The bacteriology is usually polymicrobial in my experience, and you're looking for this bug, this group A beta hemolytic streptococcus. It's a bad actor, and it can kill a patient very quickly. Swelling, advancing erythema, bullae, mottled skin, mottled skin. And the few patients that I've seen in the past couple of years, this has been sort of a universal finding. And these patients are very systemically sick. They're managed by teams. There are some things that we need to talk about are mimickers of infections, not actual infections. Look at this gouty finger. Now, I showed you this picture at the beginning of the talk. This is a gouty finger. This isn't infected. Debridements of these gouty fingers can be done. Sometimes they're fraught with complications and they're headaches later. Acute calcific tendonitis can mimic an infection. Pyogenic granuloma, that's this picture on the end here. I had one of these, and it was quite a thing. They tend to bleed, but they're not infections. Pyoderma gangrenosum, brown recluse spider bites. These are things that can be really bad. And always remember, a skin cancer can look like an infection. And I've had a couple of those myself over the years. Put this in massive font. We're getting towards the end. The most likely pathogen is Staph aureus on a test or in life. It always is. If you're looking for intravenous, sort of something associated with intravenous drug use or diabetes or immunocompromised patient, just remember these infections are polymicrobial. They have gram-positives, gram-negatives, and anaerobics. This is really important because you're going to go to the operating room, you're going to do a procedure, you're going to want to culture all different kinds. Aerobic, anaerobic, fungal, AFB, gram-positive, gram-negative, these are all possible sources of infection. Getting towards the end here, I wanted to show you a slide that shows that antibiotic-resistant infections continue to be on the rise. They've been on the rise since I was a med student, and they will continue to be on the rise. And the rules of engagement for infections will likely change because of this. So the take-home messages. First, what did we talk about today? We talked about a bunch of hand infections. We talked about appropriate treatment, and appropriate treatment is often surgical. We talked about the few controversies. There are few controversies here. We talked about a couple of cases where you really need to monitor these and not do surgery. And we talked about how management is part of a surgical practice. It's part of everybody's surgical practice. And you have to know what to do. If I had to give you one key take-home message, it's that many people believe that hand infections need very specialized training. And I believe that, but what they need more is aggressive management. I'm a hand surgeon, but I carry a CAQ in sports. And my sports colleagues, they treat hand infections. Everybody sees and treats hand infections. And so it's important to know that aggressive management or appropriate aggressive management is a key. I want to thank you. This is my crew that I work with in the Center for Orthopedic Research and Translational Science. These are the other AO Trauma North America Hand Online Hand Surgery Essentials webinars. And you can access the recording through a link that's going to be sent out tomorrow. I'm sorry I keep on going back and forth. And I hope you enjoyed this lecture.
John, that was great. I'm Kyle Bickel. Hello, everybody, to our audience out there. I hope you enjoyed that talk as much as I did. John, that was an outstanding survey of the world of hand infections. I would encourage any of the members of the audience who have any questions to ask, just to type your questions in the Q&A and we'll bring them up in our discussions. John, I got some key points that I'd like to summarize and repeat for the audience just to drive them home because I think they were really important. Number one, you mentioned early in your talk that diabetes is such a common concomitant of these infections and complicates the course of these infections, and that it's important always when you're dealing with a patient with a hand infection to be sure that you are or are not dealing with a diabetic, because it can change the management. It can also change the flora involved in the infection. So it's really a critical piece of information, and I would agree with that strongly. I think one of the most important things you brought up and that you summarized very well is the fact that physical signs and physical examination in hand infections often supersede the utility of laboratories and some of the other studies that we often get with other clinical problems. A good physical exam and a good knowledge of the surface anatomy and some of the common findings, such as you mentioned, the mottled skin in necrotizing fasciitis and the loss of palmar concavity in deep space infections. Those are really critical findings, and just an astute examiner can make a diagnosis very quickly and lead to treatment in a more expedient way without having to waste a lot of time and a lot of money doing some unnecessary tests that might not add anything to the picture. So I would second that statement as well. Also, you talked about how in infections, whatever you do surgically, the most important principle is externalization of the infectious material and the purulence. And again, you know, we're always taught to try to clean things up and leave a tidy wound and to close incisions precisely. And this is one of those instances where skin closure is secondary to adequate debridement and externalization of the bacteria. And in fact, leaving the wound open is preferable. Next, I think it's important to know the safe zones that you mentioned, because a lot of these different infections require incisional drainage, and it's not always akin to making a primary incision in a clinical problem. You have to know where you're trying to get to from the skin surface, and you have to know where the safe zones are to avoid injury to the underlying nerves, tendons, arteries, and other vital structures. So it's important to have a good working understanding of those safe zone incisions when we're treating these infections. Also, I think it's important to know that there are specific flora responsible for very common infections. You mentioned how Staph aureus is by far the most common etiology for things like paronychia and superficial skin infections, and that there are some more specific flora responsible for human bite and animal bite infections, and understanding what those flora are when you're treating those infections can lead to more effective antimicrobial therapy. So it's important for the people in the audience to familiarize themselves with all of those different organisms. I have a question for you just in terms of your management. You know, most of us are called from the emergency room to evaluate these patients, and there's a pretty broad variation in my experience in terms of the ability level and the understanding level of the ED staff. Is there anything that you try to impart to ED providers when you're there treating them to try to facilitate more accurate referral, allow them to understand and treat the infections they're capable of treating safely, and when to call a specialist to avoid having to go in the middle of the night for things such as limited cellulitis in the hand, which doesn't really need a hand surgeon at 2 a.m. What's your approach to that, John?
Well, you know, I mean, everybody has different training. You know, I learned early on, a few years ago, that the best way to deal with that is to actually go to the emergency room and give them a talk every year. I used to give a talk about sort of how we think about infections in the hand, and you know, because I do some other things, knee and shoulder. And I tell you what, the consults got a lot better. Cellulitis in particular, because you know there's always this friction between who's admitting the cellulitis. Cellulitis in particular went away, and another thing that started to happen was there was imaging to prove there was or was not a collection. We as surgeons, as everybody knows, we as surgeons, we are much more interested in collections of pus. And so it settled a lot of things to do that. Still, I got called, I told the audience that I got called for a compartment syndrome of the finger. So there's always going to be sort of differences between what we know and what they know about these kinds of structures. And there's always going to be a disconnect. You just hope the disconnect doesn't happen at 2 in the morning every time, because 2 in the morning is a bad time to get called. But that's helped us a fair amount, both here at Penn State and at in Rochester.
Yeah, I think those are all good points. Have you incorporated ultrasound more into diagnosis of deep space infections and evaluating for fluid collections as it's become more available in emergency rooms and offices? Is that more and more a part of your evaluation of these infections?
Yeah, I'm smiling because I haven't and everyone else has, and appropriately so. In the emergency room, I'm very likely to end up with a resident calling me. By the way, I forgot to mention the resident who helped make my slides, and I have to do that or else I'll feel bad. Sean Buffano is one of my residents, and he made many of those slides for me. But you know, I'm very likely to get called with an MRI, and so it's one of 2 ways to do it. I like ultrasound. I haven't any problem at all, but it just hasn't been a part of sort of our university practice in the emergency room. In clinic, it's a big part of everything because we have them in clinic.
Thanks, John. I'd like to bring Kevin Malone on board. Kevin, are you out there?
Yep, I'm here.
There you are. Yeah, there are a couple questions in from the audience that I think are worth answering. One is, can you elaborate on how to differentiate between dactylitis and a tendon sheath infection? Can debridement be useful in dactylitis, or is that just limited to tendon infections?
So, you know, for me, you know, dactylitis is, you know, just fusiform swelling of the fingers. And I think you have to, you know, differentiate between whether this is an infectious etiology or inflammatory arthropathy or those type of things. And so Canaval signs are very important, although dactylitis is one of the canaval signs. You know, you want to make sure you're assessing for tenderness along the flexor tendon sheath, pain with passive stretch. You know, the swollen finger is going to sit probably in a little bit of a normally flexed position anyway, and then be swollen. So those are two of the signs already. So, you know, looking for those other two signs, laboratory tests, you know, looking white blood cell count, sed rate, C-reactive protein, history, you know, do they have any known conditions such that might produce a big swollen finger? But it can be a diagnostic challenge to differentiate between dactylitis, you know, just diffuse finger swelling and an infectious situation. And I think, you know, given what John highlighted as to how bad some of these tendon sheath infections can get, if you're not sure, it may be the better way to be more aggressive with, you know, exploring, taking cultures, debriding, and making sure.
So if you do diagnose suppurative tenosynovitis, you've differentiated that from dactylitis. Do you have a preferred method for irrigation and soaking the deep tissues? What's your preference? You know, we were all taught the catheter method where you have proximal and distal incisions and you thread a catheter with several holes in it up the sheath. It's, you know, pretty invasive. You have to leave it in for a while. And do you feel that that's necessary? Is that still what you do, or what's your preference in terms of treating those infections?
You know, we've all read the articles about leaving the indwelling catheter in and relying on the nursing staff to,
Right.
you know, irrigate the sheath, and it doesn't happen.
Right.
You know, the catheter is going to fall out. The nursing staff isn't going to do that. And so, you know, I do tend to make, you know, a proximal or a distal palmar incision and then an incision distally over the tendon sheath, and copiously irrigate the sheath with, you know, a large amount of fluid, and making sure we're getting clear return at the end. I think, you know, the point that John made about avoiding a Brunner incision in these type of situations is important, because with a big swollen finger, the apices of those Brunner incisions can become necrotic, and then you're looking at the tendon sheath and you've got a big problem. So, you know, a midlateral incision, I think, is great, because even if you can't get that closed, that will granulate in okay, and the tendon sheath is protected. But I tend to try to open up the sheath just proximal to the A1 pulley, or maybe open up the A1 pulley with a little bit more extensile of what would be otherwise a trigger finger incision, and then something distally, and irrigate. We might leave a little packing, particularly in the palmar wound. It is hard to put packing in the distal wound. And then for me, I know one of the questions was, you know, what do we use for our soaks? For me, it's warm soapy water. You know, you can use peroxide, you can use betadine. You know, I want to make something easy that the patients have for when they go home, because sometimes we might ask them to do that when they get home. And so just warm soapy water, I think, is more than adequate in that position and that situation. And then, you know, stress again the importance of range of motion. You know, a swollen finger is going to stay swollen until the patient really gets moving on it, and just the dynamic pressure gradient that is created with active range of motion will help not only express further fluid and edema from the finger, but you know, just really help reestablish functional range of motion.
Hi, Nora.
Hi.
Can you talk a little bit more about suppurative tenosynovitis and the postoperative regimen that you think is necessary and helpful after debridement when the infection's starting to clear? Because we all know that the next step in recovery is stiffness. These fingers turn into just blocks of cement if we allow them to, and it happens pretty quickly. How do you like to approach that?
Exactly. So I think stiffness is, even in the healthiest patients, that's one of the quickest things we see. So the best way to combat that is early motion, like Dr. Malone said. And I'm also a proponent, as you are, Dr. Malone, of soapy water. I think betadine and products like that are overused very commonly, especially if the infection is gone and we're just dealing with someone who now is perhaps coming into therapy, is finished with antibiotics if there was any, and now is primarily focused on motion. So at that point, my job is teaching that patient exactly what they need to do to go home with and to repeat routinely today, but mobilization that will suppress any sort of tendon adhesion, capsular thickening, any sort of fibrosis in the joint. So these are patients we like to keep a close eye, especially early on. And like I'm talking 3 times a week, sometimes even daily if we need to, from an outpatient perspective, depending on where they live. Telemedicine has brought us a whole new aspect with COVID as well, of now checking on these patients even more frequently if need be. But that's probably the biggest thing I would say. And delayed diagnosis, just as a proponent again of surgery in general, delayed diagnosis is basically associated with all of these things like lost motion, with adhesions, tendon ruptures, deformity, and risk of limb loss. So you guys finding it is and acting quickly is the number one, and then the second is us getting involved quickly as well to get that mobilization going.
Thank you for that. What are your thoughts about splinting in these infectious cases? Do you like to send them home with a splint, or do you just encourage them to bandage and move and not immobilize the finger? What are your thoughts? I know that there are 2 schools about motion sometimes exacerbating inflammation and irritation, and yet the longer people splint, especially if you have an unreliable patient who may not be back as often as you want, they may stay in the splint too long and become stiff.
Yeah, you get a good read on the patient. How fearful are they of moving? How much dressing do they need? If they're already somebody who is quite suppurative, or pus is gone and you're just dealing with an open wound that a hand therapist should be managing, if there's a lot of dressing anyway, that may not be someone who needs a splint because they're already so restricted from motion as is. Edema is a motion restrictor too. If we are using Coban as a means for swelling on top of a dressing, already that patient has a bandage that in theory is acting like a splint. So if there's a fearful patient in combination with that, I'm probably going to steer away from splinting because I'm afraid they might use it too much. But if I've got somebody who's really active, who is working in any sort of medium, who is, anything from a gas station attendant to near a swimming pool to anything that has open debris or liquids, that's somebody I'm going to probably be more inclined to perhaps splint daytime, but have a really good conversation with about has to come off, every time you're out of a work site or in a safe environment, for motion, for washing. I think that's another big thing we have to bring up with patients is hand washing. People are super afraid to just wash their hands with regular soap and water, which is super crucial. I beg patients, minimum once a day. So I think there's a lot to the patient, what they're showing you, how much dressing is on them, and then how stiff are they. If they're really, really stiff, I'm staying away from a splint.
Yeah. John, you look like you want to add to something.
Yeah, I might chime in here. I think a lot of the therapy gets set up right at the time of surgery. So I don't splint these after surgery. I splint lots of things, but I don't splint infections after surgery. And the reason why I don't is because I'm trying to convince the patients of something that makes absolutely no sense to somebody who's not a surgeon or not a therapist. So I set it up right then. Before I do the surgery, I'll often tell a patient, look, you're going to have a hole in you, you're going to have a gash on you, and you're still going to have to move that finger or else it'll never move again. And people are going to try to help you move it, and you're not going to want them to. And I'll tell them that just because it's so hard to move something that you're convinced you shouldn't move. And it's really important. Over the years, I've learned to do that. And our therapists actually like it when I do that. Because it makes their lives a lot better. So with soft dressings, I agree with the soap. How many disasters have we seen because of too much peroxide used on a wound? And so I like soapy soaks, and I think it works out better that way.
Great. Thanks, everybody. I think we'll go on to a couple of clinical examples. I'm going to start by sharing my screen. And I hope everybody can see this one. So I have a case of a 52-year-old gentleman with 6 months of increasing right palmar swelling. He presented with limited digital flexion with a lot of soft tissue swelling from the palm extending into the index through small fingers. His left hand was completely normal. He didn't recall any trauma at all. He had mild pain with flexion and was only able to generate a 3-centimeter tip to palm deficit when he attempted to close his fist. However, he remained afebrile. There was no adenopathy on exam, no erythema, and cannibal signs were negative. Those are all the points that John was talking about in physical exam. He didn't have a history of trauma and he had no systemic signs of infection. His past history was significant for diabetes, but he was well controlled. He'd had type 1 diabetes since he was a young man, and he also had controlled hypertension and medicated coronary artery disease. He worked as a mail carrier, but didn't recall any trauma either at work or at home. We got x-rays which were normal, and his laboratories were normal with the exception of a markedly elevated SED rate at 38. See if I can get this to advance here, I'm sorry. There we go. So in absence of an obvious etiology and with normal films and an unknown path to possible infection, the next step in my case was to get an MRI of his hand. And what we saw was really profound proliferative synovial inflammation extending from the proximal palm into each of the fingers. It did not extend into the thumb, and it was limited to the flexor surface of the hand. There was no extension onto the dorsal part of the hand. There was no deep space infection. It was really tracking along and in the synovial tissue. It appeared as nodular and granulomatous chain lesions along each of the flexor tendons, extending all the way out to the level of the DIP joints. There was no erosion of any surrounding structures. The tendons, although they were surrounded by this material, looked otherwise intact, and there was no joint invasion. Because he was afebrile and because this appeared as granulomatous tissue in the hand and we didn't have any other way to get an accurate diagnosis, the next step was in fact to take him to the operating room and performed an extensive exploration, and this is what we found. So this is his right hand, palm to the right, fingers to the left, and you can see that along each of the flexor tendons from the index through the small fingers within the synovial sheath, there's this proliferation of this thick spongy material. You can see the chains of this material built up along the synovial tendons, bunched up between the pulleys in the finger, but sparing the nerves, the arteries, and the tendons themselves were functional. Because we were there and I didn't feel that this was likely to benefit only from an incisional biopsy, the next step was to go ahead and remove all of this tissue and do a radical tenosynovectomy for therapeutic purposes. So that's what we did. We removed all of the infected synovium, leaving all of the vital structures behind. You can see some of the pulleys were intact. Some of them were destroyed by the proliferative material and had to be sacrificed, especially in the index finger. The middle finger and small finger, we were able to save the A2 pulleys. And my clinical suspicion, because I had dealt with this before, was that this patient had atypical Mycobacterium marinum infection. So I want to talk a little bit about the atypical mycobacterial infections in the hand, Mycobacterium marinum being the most common of them. It's still an uncommon infection. The incidence is only 0.25 out of 100,000 population. And it typically occurs from a marine or aquarium environment. People who work in the ocean, people who have boats, people who clean barnacles off of their boat, but very often people who simply have an aquarium at home that they maintain. Interestingly, as opposed to some of the other atypical mycobacterial infections, which we saw a lot of in the early days of the HIV crisis, these are often immunocompetent patients. It does not presuppose an immunocompromised host. And the method of infection is some form of skin trauma, often minor. A simple paper cut or a puncture, as John mentioned in some of his infections, is enough in the right environment to introduce this into the tissue. It's a slow growing organism, and therefore the diagnosis is most often delayed and is frequently more than 3 months and sometimes more than a year after the exposure. So patients often forget that they had exposure or that they might have had a small wound on their hand leading to this infection. The organism grows in a cool environment, and therefore skin and subcutaneous tissue are most often involved, tenosynovium as well, but it doesn't often lead to deep space or systemic infections. The exception to that is in the immunocompromised patient. And in those patients, as with many infections, the course is much more aggressive and can in fact lead to fatal infection. In order to treat these, we have to have a high index of suspicion. So if you go back to my initial exam of the patient's flexor surfaces, You know, this doesn't look like suppurative tenosynovitis. This is not giant cell tumor of tendon sheath. And so having seen this before and being aware of the infection, I was tuned in to what this was likely to be and therefore knew that the best way to manage this surgically was extensive debridement. But post-operatively, if you're not suspecting this organism, it's a bit of a quandary because it's such a slow-growing organism that cultures, which are very specific, in 28 to 30 degree medium can often take more than 6 weeks to come back positive. And you certainly don't want to have the patient waiting for a diagnosis for 6 weeks, sometimes with some recurrence of accumulated granulomatous tissue. So what we typically do is if we have a very high index of suspicion based on our clinical exam and the presentation, we initiate appropriate medical therapy after surgery, even before we get confirmation on the cultures. Treatment is usually surgical debridement coupled with chemotherapy. And interestingly, there is not a clear consensus about the optimal drug regimen because these are uncommon infections and there's very little well-controlled data out there about what the optimal treatment is. Most commonly, the drugs that are cited are rifampin, ethambutol, doxycycline, and trimethoprim sulfamethoxazole. They're all effective, and some physicians treat single drug therapy and some physicians use multi-drug therapy with 2 or sometimes even 3 drugs. I don't think there's a lot of data to support multi-drug therapy in this organism as opposed to Mycobacterium tuberculosis, of course. Again, the duration of treatment is somewhat controversial because we don't have really high-level evidence to support 3 months versus 6 months versus longer. So on average, it's 3 to 6 months in most surgeons or infectious disease practitioners' hands. And resolution of these infections is fortunately common with appropriate treatment. And the key is having the knowledge to have a high index of suspicion in this clinical scenario, in the hand limited to the skin and superficial tissues with or without a known history of trauma in a marine environment, because often it's forgotten, so that you can initiate appropriate treatment and lead to resolution. And at the end here, I've listed a good reference from the Journal of Hand Surgery, looking at a large experience in a tertiary care medical center, which goes over the organism, the etiology, clinical presentations, and treatment. So I thought that would be an interesting case to talk about. Again, the importance of clinical exam that John discussed so well, and management of this particular organism. See if we have any questions. One of the participants said they had a similar case with tuberculous infection in the hand, and they felt it was difficult to differentiate because the inflammatory markers were high, but clinically it was relatively indolent. And I agree with those comments. It's very accurate. John, I think you have a case to present for us, unless somebody else has questions.
Hey,
Hi,
John.
Chad.
I do, I have one.
John touched on 3 things. He said calor, rubor, and dolor as the signs of suggestive infection. Described by Galen, the 5 signs, the remaining 2 being tumor and functional lisa, swelling and loss of function. And I think canable signs are merely an extrapolation of those signs described thousands of years ago. But if you have a rip-roaring abscess, I think you'll always see those 5 signs, except in diabetics where the rubor might be muted. And in people with dark skin tones.
Thanks for clarifying that, Chad. It's important. John, you had a comment or question, or do you want to jump into your case?
I have a case, I think it's a case in 3 slides. So I had, this is a case from last week here. So I had a 56-year-old male. He's a air conditioning worker. He works on industrial-sized air conditioning rigs for large buildings. And he had 5 days of swelling starting 6 weeks post-flexor tendon repair of the small finger. He had limited digital flexion due to a tender soft tissue swelling from the palm into the small finger. He had no palmar tenderness. He had a flexed posture. It was minimally tender to motion. He was afebrile when he presented. No adenopathy. He was positive for erythema. Now, the surgery that was 6 weeks before was a zone 2 flexor tendon repair. It was kind of right at the end of zone 2. And the patient seemed to his wife and to myself like he was going to maybe start using the hand before we told him to. It was a 6-stranded repair, but I supplemented this repair with an external button because it was right at the end of zone 2, and I felt like he might pull it apart. And I put the button on top of the nail. His past medical history was negative, but I did do a previous surgery on him. I did an MCP joint fusion in the same hand on a different digit on his middle finger about a year before. His labs were reasonable. ESR not that elevated, only 25. White count was 7. CRP was I think it was 6 at the time. So my question, I'm sorry. This was a picture of his hand that first time he came back. This is 6 weeks plus 5 days. This is a well-lighted, a poorly lighted volar sort of picture. And this is what his nail looked like. I had taken the button off at 6 weeks. So my question is, does anybody want any studies? Or has everybody seen enough or not enough?
An X-ray.
Say again?
X-ray?
X-ray, you want an X-ray? Anybody else? I got an X-ray. Here's the X-ray. This is my old fusion site here. It is fused. Believe me, it really is. And of course, the radiologist read this as osteomyelitis, which was somewhat disappointing. But this is the actual films. What would everybody do?
John, why did he have a fusion of his MCP joint?
For arthritis. Degenerative arthritis. No, degenerative, yeah, degenerative osteoarthritis. Does anybody want to do anything?
Does he have psoriasis?
No.
Why does his nail look so dystrophic?
Well, it didn't look dystrophic when I put the button on.
So you think the dystrophy is a direct resultant of your button, you think?
The button was sitting, the button, I don't know, but the button was sitting right here.
Yeah.
His button was distal to his nail fold.
Okay, and he's tender volarly or dorsally?
He's tender from here. He's tender right here. He's not tender at all here. He's a little tender here. He's tender right here.
John, what type of infections do HVAC people get?
I don't think he has pneumophilia, but I didn't think about that at the time.
Did you get an ultrasound at all?
No. You're not going to like what I did. It's okay. I'm showing this as an example of something that we shouldn't do. I like to show sort of these kinds of cases because we see a lot of things and a lot of us are unwilling to say when we should have done something different.
All right, why don't you go ahead, John, tell us what you did.
Okay, here's what we did. Our first surgery, this flexor tendon repair went well. He had swelling at 5 weeks, so we pulled the button and he improved, just pulling the button. He had swelling a week later at 6 weeks. I admitted him for antibiotics and he improved. He improved a lot. So I let him go. He had swelling again at 7 weeks. And then I took him to surgery and I had a consulted ID. In our institution, we have ID in the orthopedics department. We have an infectious disease doctor. I removed the repair because it was infected. It grew out Pseudomonas. He's been treated with a PICC line and Cipro IV for, I think, about 4 weeks. And he's completely resolved now. He's about 2 weeks out from this surgery, this debridement surgery. And so the thing I learned from this was, I wonder whether or not I would have, I should have debrided him here. Just pulling the button made him better. Maybe I could have done something here or here to make him better quicker. The thing that I wanted people to take home is that post-operative infections, which we didn't talk about, post-operative infections, they're common and they're they're not strictly dependent on the use of postoperative antibiotics, which incidentally I did use after the index procedure. These sometimes can present in a subacute kind of fashion. And I was going to ask the group, what could we have done better? I was wondering what everyone would say to this.
John, I think this is a really important case because, you know, as surgeons, it's very different when you're looking at your patient and you feel responsible for their clinical course than when you get called to the emergency room, you know, to see somebody else's infection from some misadventure of their own making. And it can cloud our thinking, and we're often a little bit reluctant to be as aggressive as we would be otherwise in a very similar clinical scenario, but with a different etiology. And so I think, you know, your self-critical examination is really admirable. And I think that as surgeons, we always have to be open to the possibility that this is an infection in a surgical wound, as much as we hate to admit it. However, having said that, I don't know that I would be as critical of your management as you are. I think that pulling the button was certainly a reasonable first course. You know, it's a fomite in the wound. It can be responsible for local irritation and even a localized infection. And in fact, the patient started to get better. So there was no reason for you to be more aggressive at that point. Presumably, there were no systemic signs of a rapidly fulminant infection. And therefore, you know, a careful but close observational course, I think, is absolutely appropriate. You didn't let this get out of control. You kept close touch with the patient. And when it became obvious that this wasn't going to go away, you know, you stepped it up to the next level. So I think that's exactly what I would have done. But I think your point about nosocomial infections and postoperative infections is really important, that we have to be open-minded as surgeons and, you know, take the emotional component out of it and just look at these as infections regardless of what they're caused by and treat them just like we would any other infection.
That's a good point. I think that most of the surgeons who see a case like this, and these happen, you know, the last patient you want infected in the world is the patient you operated on. So I think that that's an important point. I wonder whether a strict six-stranded repair really needed a supplementary button. If I was happy enough, I got a six-stranded repair in the guy. And that's a pretty darn good repair. If you've done them that way, you can hang a Honda off of those fingers and they're fine. So I think it's important but I think it's really important to, especially for some of my residents have logged in, or my former residents have logged in. I think it's important for people to kind of look critically at what they do. You're not God's gift to the game. And you're going to have situations that you want to unfold differently. And debriding this patient was the thing that made them better.
Great. Do we have any other questions from the audience? I think we don't appear to. So I'm going to take a moment to thank John for excellent presentation. Kevin, you have a question?
No, I was going to say, I think we've answered them all. So great talk, guys. Good job.
And thank you, Kevin, and thank you, Nora, for contributing. It was really helpful. And thanks to the audience for showing up for our presentation. And I encourage everybody to come to the subsequent presentations that we have. I think we have a really good series that's coming down the line, and I look forward to seeing everybody again in the future webinars. Thanks very much.
Thank you.
Thank you.